Good morning. We are just starting our keynote lectures session, and I would like to announce my friend Jeroen Vermeulen. And it is a great pleasure to share a little bit about his CV on the beginning. Professor Jeroen Vermeulen started to deal with developmental medicine and muscle pathology very early. He got his PhD thesis about the role of dopamine D1 receptors. Since 2014, he is working as a child neurologist at Maastricht University Medical Center. And since 2017, he is appointed as a professor in child's neurology. He published a lot of papers, more than 140 peer-reviewed articles, mainly in the field of cerebral palsy. In this field, his research is focused on diagnostics, especially MRI techniques and the clinical assessment of spasticity and dystonia, and on treatment, especially focused on the intrathecal baclofen, deep brain stimulation, and functional electrical stimulation. So I'm very happy to have the possibility to introduce and to announce his keynote lecture about the high-tech treatment in cerebral palsy individual challenges. Please, Jeroen.
Thank you very much, Mark, for the nice introduction. And I would like to congratulate you with your nice congress. I think it has been a major achievement to just change it from a regular congress to a completely virtual web conference. And I think you succeeded very, very well. So my compliments to your whole team. And I also would like to thank the organization for the invitation. I feel really honored to have this platform and to share my thoughts about high-tech treatment. So first of all, I would like to start with my disclosures. So then if we look at treatment, already the Greeks started with to therapeion, to minister, treat medically, then healing was also introduced, and then it changed in the mid-19th century to therapy. And if our patients would look into the Cambridge Dictionary, they find this, a treatment that helps someone feel better, grow stronger, especially after an illness. I think it already hints towards the WHO ICF model. So that you have a health condition and you would treat it and you would treat spasticity, and then they should feel better and develop better. And I think that is the whole idea about treating a certain issue and then looking at more activity level and especially at the participation level. And then of course we have environmental factors and we have personal factors, and I will go a little bit also focus on the motivation. If we look at the treatment in cerebral palsy, and I think that the group of Jana Novak did a great job, and it was here one of the previous papers where she showed that with the lights, green and orange and then red, what you should do and do it or probably do it or unknown. The question, of course, is how does this relate? So we see SDR, botulinum toxin, diazepam, very high, but if we look at improved self-care, there are not automatically, it is clear that it will also help for these conditions. So actually that is something that we have to look at in a more careful way. Where did we start? And I think this is a nice example, mobility training in Maastricht, where the nurses took the children out for cycling experience, and later also with the polio, which is now almost extinct in the Netherlands, they had mobility training in a swimming pool. And what is high-tech treatment? Does it involve computers? It's expensive, it is new, hip, last resort. It is something that the parents want. And of course, this was also high-tech treatment in the 1950s, where they thought that the disabled children, they did not experience the normal things like sitting in a car. So they developed something that they could experience the experience of riding in a car. And you see here the small cars which were pulled, and they thought that would be something very nice for the children. Actually, that is something that we see. High-tech treatment, and what I've chosen is to cover 4 areas, and I just want to give some examples. I will not discuss everything on prevention, but I will show some examples and the problems with individual challenges. And prevention, neuromodulation, health aids, and training. So these are the 4 topics that I will go into. So we'll start with prevention. If we look at prevention and prevention of cerebral palsy, I think that cooling is one of the best examples of an effective prevention. The effect is decreased death and major disability in survivors. As you can see in this Cochrane analysis, that it really favors hypothermia. And you see here a baby in the package, and it causes hypothermia from 34 to 35 degrees. It's really effective. Is it effective for everything? No, not really. What we also see is that there is some discussion about mental development. So what we see here, that if we look at the mental, which was the Bailey score, what we see that there is a little bit a trend towards favor standard care. And it is strange and I think that we need large post-hoc analysis to show what is the effect on the mental ability and what we can do to improve that also. If we now look further, and hypothermia in all the analysis was really advised as something that you should do. And I think in the Netherlands, and I think almost in all Europe, this is a practice that is used everywhere to prevent cerebral palsy. If you now look at stem cells, that's a really different story. And I think that stem cells, everybody, at least the public, thinks that stem cells are used for everything, but we have to look where we want to address our stem cells at. So we can use it for hypoxic ischemia infections. We can use it to cure neuroinflammation, which is, you have to do something about microglia, astrocytes, systemic response. And you have to consider which type of injury will you look at, white, gray matter. And of course, you have to look at postnatal injuries, like due to ventilation, hypoxic and hyperoxic, sepsis, medication, feeding. And then, of course, we have to consider the gestational age of the child. So in summary, if we want to use stem cells, we should consider do we need them for anti-inflammatory mechanisms, trophic mechanisms, or regenerative? And I think that is really something really important to consider at the start. In Maastricht, we have a facility where we do experiments with lambs, with premature born lambs, and it is the way we evaluate them. We start with the MRI. You see how it looks like. Then we get our regular MRI. And of course, we do also quantitative measures to quantify the differences of the different therapeutic strategies. And then, of course, we have to evaluate the long-term outcome. And how do you do that in sheep? And we thought about gait. And what you see here is how it looks like when the sheep walks into your image. And we have to analyze. We will start a large trial this year. And we have to evaluate what are the effects and also side effects of the treatment. Okay. Proceed. Now we go over to the topic of neuromodulation. Aiming at restoring disturbed neural control. I think that deep brain stimulation is very well known for that. If we now look at the most common indication for deep brain stimulation, cervical dystonia. This is from a Cochrane review. What we see for cervical dystonia, actually, DBS may improve overall cervical dystonia severity. And the evidence actually in grade terms was relatively low. And also for the subjective improvement of clinical status, it is low, 1 RCT. And the other thing is, if we look at the next slide, and why we need really studies, and that is that we also get our side effects. And we should be really clear about the effect that these technical innovations have side effects. So if we do it in children, and if you look at the papers that are published so far, we should look at this adverse effects. And this is an example of one of the studies in children. And what they looked at was a group of children with primary dystonia and also cerebral palsy. And I think if we first look at the group with primary dystonia, what you see is that the disability scale that they used is lowering over the months. And what you see that it takes almost 2 years to get at the optimal lowering of the disability scale. However, in the group with cerebral palsy, they didn't saw this effect. And it was really clear that already from 6 months on, it was clear that there was a really clear difference between these two groups. Can we understand it? Would there be a reason for? I think so. This was targeted at the internal part of the globus pallidus. If we now look at the regular patients, the biggest group in the dyskinetic cerebral palsy, what we see is this is a neonatal MRI with the diffusion weighted imaging, where we see the central cortex, the putamen, the thalamus, and also the hippocampus. And at the later stage, we see the complete destruction of the putamen, but also of the globus pallidus, which is also damaged, and also the thalamus. Which means that if you want to use this area as a target, it won't be that successful. So I think that we really have to rethink our ideas about networks in dyskinetic cerebral palsy, especially those with severe abnormalities, to think about how we can influence these abnormal networks, but using other targets that are not damaged, because I think that is a major problem in this group. Intrathecal baclofen, is it effective? 2 years ago, we published a paper on continuous intrathecal baclofen therapy in children, and we looked at pumps, the effect of pumps. The efficacy, and what it shows really very clear is that there is on the specificity level, the function, and then at the activity level, you see really smaller effect. And I think that can be explained by the fact that most of these patients have GMFCS 4 and 5, are the more severely disabled children. And here you see on the participation and environmental factors, and you see that there are also clear effects. However, the efficacy is there, but the evidence was low to moderate. And this is one of our patients, William. He was 23 years old, and his main problem was pain due to spasticity. And we tried already several things like botulinum toxin, we did orthopedic surgery, and then we discussed with him what were his goals. And actually he told me that he was working in some kind of kitchen, he was cutting vegetables, and actually he was quite spastic but also dyskinetic. And what he wanted was to work in this restaurant again. And then we started with it, and we succeeded to get rid of his pain. And then I invited him for a discussion with students, and then he said, yes, I'm really happy how things are. But the other thing is I was so lucky in my life. And then all the students reacted, how is this possible? Because he was in a wheelchair, he was quite disabled. But he said, yes, I have all these very nice people helping in my environment, and they make my life so good, so nice. And I think that showed very much that there are small things that we can influence, but the bigger things do the patients themselves. Now, if we look at neuromodulation, we can influence tone, and this is from the Novak paper from 2020. But the question is, how does it affect self-care and function? And actually, what we see here, it is green, so we influence tone, but it is not really clear in these areas. So these are the areas where we have to focus on to get it clear, and or get them green or get them red. The last 10 years, we did a large study, and Laura Bonnefrier, she did her PhD on this study, and we looked at intrathecal baclofen treatment for dyskinetic cerebral palsy. And the two largest groups for goals for ITB treatment in these patients were caregiving and mobility. Those were the biggest. And one of these patients, I think, is a very nice example. Roman, he has uncontrollable involuntary movements of arms and hands, TMFGS 5, max 5, CFGS 3, but maybe it's a little better. He needs fixation of the arms, otherwise his arms are hurt. He has wounds and he cannot sit without any problems. And the other thing is, he was so dissatisfied with this situation that he discusses the meaning of life with a psychologist, how to proceed. And daily care and sitting was the major problem. The effect of intrathecal baclofen, actually he needed the straps for his arms and hands. He sleeps well. He started wheelchair steering again, because when he was younger, he didn't have this much dyskinesia. And of course, he wanted to see his favorite club win. And here you see him in my outpatient clinic. And you know, this is Ajax, which is the famous Amsterdam club. And he was really a fan. And that evening, his club was playing. So he had always this flag in his wheelchair. Laura Bonnefrier did this as a PhD student, this big study. She did a great job to do this randomized control trial, which we published last year in the Annals of Neurology. And this study was a randomized controlled study where we had 50 children eligible. And then we allocated 18 patients in both groups. And then actually we were able to do the analysis on 16 in the placebo group and 17 in the ITB treated group. And where our primary aim was to look at the goals. And what you see that in the ITB group, there was 41 that did not aim the goals, but it was 87% in the placebo group. And if we now look at the partially achieved goals, then the difference is even bigger, that we see that only 12% didn't reach any partial goal, and it was 87% in the group of the placebo, which means that it is in these conditions that it is really something that works and provide and increases quality of life in these patients. How to discuss the potential ITB treatment? I think that it is really important that you have to sit together with the patient, the parents, and your team. And I will come back to that at the end. Take your time. That means it is not something that you do regular. You have to invest time to discuss it with them. Discuss the goals. Are they realistic? Because sometimes people think that they will gain, for instance, motor skills, but as you have seen in the systematic review, it was not so clear that you would achieve motor goals. And then discuss the time schedule. We used a test trial in spastic CP. Actually, we do not use anymore a test trial in the dyskinetic, and we did not use it in the IDIS study as well. Implantation and also filling procedures. That takes time, and they have to come back to the hospital, which means that they're obliged to come every couple of months to the hospital. Then the next topic is hearing loss in cerebral palsy. I think it is underestimated. The hearing impairment is a common comorbidity in cerebral palsy, and the Canadian group reported at about 12%, and also in other studies it was about these numbers. It is more in non-ambulatory children with GMFCS 4 and 5. And most cases, hyperbilirubinemia was the cause. If we now look at the neonatal hypoxic ischemia, what we see in the groups that we still see more children with dyskinesia, with deafness after cooling. So that means that cooling is reserving, is diminishing the number of children with cerebral palsy and also death, but that it little bit has an odd effect on the deafness. So that means that we really have to aware in this population of children with neonatal hypoxic ischemia of hearing impairment. And in spastic CP, one of the major causes is the cytomegalovirus infection, congenital. And what we should consider is that there is a late onset of deafness occurs in CMV infected patients, which means that we need to organize audiological follow-up in these patients, and we need individual protocols. So that doesn't mean that all patients with cerebral palsy have regular to be checked on hearing impairment, that this specific group has to be checked. Healthcare aids. Orthoses, are they high-tech? Yes, I think sometimes they are high-tech. As you can see, we have different types. We have solid AVOs, we have floor and ground reaction orthoses, we have with posterior spring leaf, and we have hinged AVOs. And as you can see, those are of the highest quality of carbon with titanium with hinges. However, what we also should consider is that we need good research. And this is a very nice example of the recent Schwartz, who showed that there were some conceptions about these orthoses for children walking in crouch. But what they actually showed that this, although the principle is different, that these were both effective in this group of children. So we really need to investigate this type of orthosis. Then we go over to functional electrical stimulation. A couple of years ago, we published a systematic review on functional electrical stimulation. We had several conclusions, and what we pointed that it has a potential role as alternative to orthosis. There is some evidence to decrease self-reported frequency of toe drag and falls, and there is, however, limited evidence for the improvement in activity and participation. So will they use it? Is it effective in participation? Actually, we don't know very well. That's the reason why we developed the VESPA study, and Irene Mol is the PhD student on that, where we randomize between conventional therapy and VES, and then there's a washout period, and they start with conventional, and the other groups goes the other way around. What we see is that this is a gait analysis. We use the Karen system for that. And what you see is that this is the normal side, and this is the affected side with VES on and VES off. And this is actually the effect, what we see. And this is the plantar flexion. So it has some effect. And the goal of this patient was wanted to walk more stable. And actually our primary outcome in this study is the goal attainment scoring. And the question, of course, is, will it work? Yes, we think it works. But the question is, will it also result in the goal, achievement of the goals for the individual patient? And we hope to end this study in the September 2021 and report on one of the next conferences. And we go to the last topic, the training. Training of walking, where did we start? I think this is a very nice example in the 1950s in the area of Maastricht, where they had an environment with a lot of light, plants, and what you see here is these children could walk. They were put in this device where they could walk, and so there was only one nurse necessary to keep track of all the children. And some of the children were allowed to do other things. Gait training, and the team of Amsterdam showed very eloquently that we should do gait training. It really favors if we compare it to, for instance, physiotherapy with strength training. So that is something that works, so we should apply it. But what about robotic assistive gait training? There are potential advantages. You can increase the repetition load. It is less strenuous for physiotherapists. They don't have to care the patient, or there is no risks. But the question is whether it works. And if we now look to the current evidence, only higher evidence studies were only recently performed. And there was a first study from Jin. They showed small effects. However, they could not confirm their effect on follow-up. This effect from Amman showed no effect at all. It was completely randomized. And also the group of Pool showed that addition of robot-assisted gait training had no additional impact on improving indoor walking speed, goal attainment, functional mobility, independence, and gross motor skills. Of course, the question is whether you can sometimes use this to investigate principles to see how it works. But that one thing is really clear, that we need this kind of studies to prove or disprove the use of this kind of instruments. And if we look at the treadmill with a virtual environment, the Cairn or Grail, and Jaap Harla yesterday in his talk showed it in more extensively. And I think this is a very nice example where you can use it as a training facility. And the question is, of course, whether you should use this for patient care. But I think these kind of devices are very nice to show a proof of principle. And I think that Adam Booth showed it very nicely that you can use this kind of intervention to show virtual environment. But I think with the newer thing that you don't need this really big setup, and that you should look at things that we can do at home for the patients. Or we can do something else. For instance, here in Atlanta, in Maastricht, what we do here is that the patients are trained, and you see the other one here with his walker on a very small stairway to practice his skills. And you see Eugène walking behind the patient. But I would like to draw the intention. You can also use this not only for the walking patient, but also those patients in wheelchair. They can practice these kind of things. And I think that is really important to adapt the environment or just practice in the environment itself. Training of the hand, that's something different. Because if we look at the hand, it has these different shapes, forms, and this is from the website The Spastic Hand, and I think they have very nice examples of that. And of course, if you think about the cortex, what you see here is the hand, but it is very near to the face. So what you will see is not only the hand, but also the other abnormalities in these patients, which makes it very hard to devise skills that or a training that is just for one patient. And what are the mechanisms of plasticity? Martin Stout showed almost 20 years ago, very nicely using transcranial magnetic stimulation, that with a small lesion, you get contralateral innervation on both sides. With a little bit larger, you get contralateral and ipsilateral innervation, which is shown here. And if you have a very large lesion, you only get ipsilateral innervation. It influences. But what makes it even more complex, and it was from Marco Wilk a couple of years ago, that if you have this small lesion, then there is still on one the motor innervation and also sensory innervation is on one side. But when you get plasticity of the motor system, it's going to the other side. The sensory system is still on the other side, which means that they have to interact. And I think this is one of the problems. And Professor Bleinhoeft from Louvain, she showed in very nice studies the effect of training of the hand and arm by minimal intensive therapy, including lower extremity. Function improves and goals are reached, which is very nice. But in one of her latest papers, she also showed, using diffusion tensor imaging, that there is also indications that the cortical spinal tracts are changed. And that means that when you train early and start early, that you can influence the nervous system. And I think that is really important. And if you now add robots to this kind of training, and it is a little bit disappointing. The first thing is that we have to choose what we would like to train. Do we like to train the affected or the unaffected arm? And I think that there are some cases that now show that also that it helps to train the non-affected arm. And this is, for instance, an interactive game, 2009, a feasibility study. However, no follow-up. So there is no evidence that it will work, and that is also for the other. Sylvain Bouchard, almost 10 years ago, he says that about robotic training contributes to clinical practice currently is the provision of intensive repetitive movements. So I think that we really need additional studies to show the evidence of robot training. Or you could do it at home. And I think this is a nice example. This is something to comb your hair, but it can also be used to cut. And it is Eugène who really thinks about this kind of solutions. And I think it's practical, real world goals, and you really can apply it directly at home. So that is something which you should consider. Factors in the success rate of treatment. I think that you should need the whole team, the family. And I think the group of Ross and Boyd showed a couple of years ago that motivation is something that is really important. And there are differences between the children, and that the social background of the children really matters, and that we should be aware of these effects. However, it will be very hard to influence, but we should take into account these factors. And I think that is something that should draw more attention in the next coming years. Does age matter? Yes, I think so. And this is from the Netherlands, the GMFGS curves. And what you show that in these children, the goals are reached later. So in the GMFGS 1 is later, and that they are reached very early. So that we really need to practice in a very early phase when we can influence the development of these children. Does the goal differ per age? Yes, of course, if we want to do advanced games, small children like Mario, but the older ones, they really want something real like this. And I think that we really should consider that sometimes the games that we make, they are just not like the games that they really want. So the take-home message, I think the best treatment, the main thing is the goal for the patient and parent and caregiver. It's age dependent, culturally dependent, and economical dependent. High tech, I think what we really need is a high level of evidence clinical trial. That is really what we need, and with the focus on activity and participation. And then we have to consider the individual challenges, age, family, environment. And I think to do this in the right way, we need a multidisciplinary team. You cannot do that alone as a practice. And I'm really happy that I'm in Maastricht, and we have here a team, our nurse surgeons, nurse, the rehabilitation doctors, the physiotherapists in the gait lab, the nurse surgeons, the speech and language therapists, the people from the gait lab. Then we have our team for the stem cell transplantation. And then I'm really happy in the Netherlands and also abroad to have collaboration outside Maastricht, where we consult each other and can ask questions or resolve problems that we have. So I would really like to thank you, everyone. And as you have seen, we are doing a lot of work, and I really hope to present in the next years and the conferences, and hope to see you back. Thank you very much for your attention.
Thank you, Jeroen. I think that it was a very interesting presentation. Thanks to that. We have one question from the audience till now, so let me read that. It's a very easy question, probably for you. And the question is, how much time did you need to complete your randomized control trial with ITP?
I think that we started in 2009 to design the study, to get them funding for it. And we published the results in 2019. So we have been busy for almost 10 years. And one of the things was really problematic to get the inclusions. And one of the problems is that in the beginning of the study, intrathecal baclofen was just as offered also as treatment. And then our trial safety monitoring board, they advised us that this was a phase 2 study. And they said, what you should do is that all patients that have dyskinetic cerebral palsy, that is a trial, that is not current treatment. So what we changed, so we did not, in the beginning, we also offered this as a treatment, but then we changed our strategy a little bit. And then I think that that really helped to complete it, but it took almost 10 years. Yeah. So.
Yeah, there is another question, with regards for hearing impairment. Were you referring to hearing aids, or is there some evidence for cochlear implants in cerebral palsy?
Yeah, I think there's limited. It is hard to, you don't compare a group that you won't implant and the other, but I think it works. The problem is with the dyskinetic cerebral palsy patient, because if they turn their head around very fast, what you see quite often is that they lose their cochlear the devices on the head. And also, I think there is also what I pointed to, that the damage in some of the children, for instance, with the dyskinetic cerebral palsy, they have also hippocampal damage. And what you see is that their span of attention is very short. So sometimes it is very difficult to evaluate whether they can have benefit of this cochlear implant. But we usually advise it. Yeah.
Thank you. One more. Two more. What is the technical development which is absolutely needed in the coming years for children with cerebral palsy?
Yeah, it depends. There are different levels. I think what Jaap Haarle yesterday showed for the diagnosis, I think the markerless gait laboratories, I think that is something that is really fantastic, because to get all these markers on children to walk is very difficult, and I think that would really help for analysis. And I think that we also, what at least in the Netherlands and together with Elegans Montbelieu, we are looking at dyskinetic cerebral palsy, that we need to increase our knowledge about dyskinetic cerebral palsy and also look at other targets, for instance, for deep brain stimulation. And we are looking for other targets and to see whether we can do something to increase the effectiveness of our therapy. Yeah.
Yeah. So it is my question now, not from the audience. So, do you see we are surrounded by the technical equipment, by the robots, virtual reality, by the high-tech resolutions for the spasticity dystonia treatment. So what is your point of view? Do you see any place, any role of the classical approach for the diagnostic and for the therapy served by the hands of the regular doctors and medical doctors and the therapists now and in the future? Or we should go directly to the high-tech technology?
What I think that high technology can only be part of the complete spectrum of treatments, and that you should offer everything. And what we always see is that children are living far from the centers, so that within our team, you have the local physiotherapists and local doctors, and that you have to collaborate with them and to advise them how to work. And I think with this COVID-19, what we learned is that we can do a lot over the web, that they don't have to come all the time. And I think that that really helps. So I think that technology is nice, but you should look at the individual patient, what is needed.
Yeah. The next, it's anonymous, but I am reading all. Dear Jeroen, thank you for this great talk. Do you consider the goal attainment scale as the new universal outcome measure for rehabilitation studies?
I think that looking at the patient, I think the goals are really important, and they should be part of your consultation. The thing to develop new things, of course, we have also to look at the other measures to see what our intervention does, and then to see whether it works or not. So we have to look. First is the goal. So what also for this functional electrical simulation, we set the goals at the first place, because that means that it makes sense for the patient or not. So I think, yeah, I think it should be the universal outcome. Yeah.
Thank you. The next, tailoring therapy should be considered in neurorehabilitation, especially ICF based. What are you think about?
Yeah, I think that this question refers to my previous answer. I think that we should look at the problems of the patients, of the goals, and should look at the underlying problem. So first, it starts with the diagnosis. A proper diagnosis is the spasticity, is the dystonia. Then to see what kind of treatment to reach the goals and to be really clear. And as you have seen from the Iona Novak papers, there are a lot of treatments where we are not sure whether it will do anything, will mean anything for the patient.
Thank you. And the last one. Thank you very much. I have a further question. What is the role of non-invasive stimulation and transcranial direct stimulation in cerebral palsy?
Yeah, it's a really good question, actually, because I wasn't able to give everything. I think the group of Adam Curtin in Canada showed very nice examples of this. It is promising. The problem with I think that the transcranial magnetic stimulation really works fine, and I think we will try it also to. First, you have to do the training. I think the training is first. That is really clear, and then to see whether other interventions will help with it. The problem with the direct stimulation is that at least at this moment, the idea is that the current is not high enough to modulate deeper structures. And that might be a problem, but that is something that will be reported in, I think, the next coming years.
Thank you, Jeroen. So there was a lot of questions. It started to look as an exam for you. So I would like to say that you passed that. Thank you. So thank you very much for your excellent keynote lecture. And yeah, it is nice to invite you for a very short break to start the next presentation as a social event, but it will be the next presentation by Michael Worok from Poland. I will introduce him just after the break. Thank you very much.